What's up, everyone? Welcome in. Body movement. You know what this is? This is episode 40.
Wow.
Pretty
Nice.
good, right?
Yeah.
We figured it out. We have Dr. Stephanie Filbay from Down Under. We had a whole mishap where I looked like pretty foolish trying to send an invite, but it was daylight savings time on the time change. So I kept sending the wrong invite for her, but we got her. We figured it out. Brother sister thing going on here. So Elson was like making me feel not that smart, like on the side, little kind of like a little shit talk. But we figured it out. So we got her. We're happy to have you. Excited to talk about a lot of the ACL, knee surgery or non-surgery kind of research and upcoming trends in the healthcare field. So welcome, Stephanie. Great to have you.
Thanks, Matt and Allison. Thanks for the invite.
Yep.
To be here today.
Elson, I know.
If you want to give a little intro, Stephanie, I mean, you'll do it better than us. But my just a bit on our relationship is, I think if you've listened before in our podcast, we've talked about the cross bracing protocol a little bit, which is Stephanie is the lead author on the paper that was published, and. I was able to talk to Dr. Cross, having some clients locally that were interested in non-operative care. So Dr. Cross was nice enough to hop on Zooms with me at, odd hours for all of us. And then we have kind of kept in contact because right now in the United States, when people are looking for this or for non-operative care, there really aren't many people talking about this, number one. And then if they are finding it, they might be reaching out to Stephanie and saying, help me. I'm in the States. No, I have nobody. And Stephanie's putting them on an email with me. And, we're trying to, make that work. So that is our background, simply for connecting. So you have a large background in the ACL field, I know, in the research field behind. So could you just give us and our listeners a little bit of your background?
Yeah, sure. So I'm a physiotherapist by training, by background. I'm still registered to work clinically, but don't really have time to do so at the moment. So I'm full-time research. I'm now an associate professor at University of Melbourne. I first ruptured my ACL in my first year of my physio degree. So I've also had some of my own experience with ACL injury, which I'm not sure if we'll discuss it later, but I had a reconstruction and a revision surgery and then a re-rupture as well. I did my PhD on the topic of optimizing quality of life after ACL injury. That was in Queensland, Australia. I went over to University of Oxford for 4 years and did a postdoc over there, and then came back to Australia, where now I'm based in Melbourne doing research. A lot of my research focuses around translating evidence into practice when it comes to ACL management. A lot of that is about comparing ACL surgery to rehabilitation alone, and more recently exploring the potential for ACL healing and possible interventions like the cross-bracing protocol that might help to facilitate that.
So with your, I'd be interested to know was it being at Melbourne, the University of Melbourne, that kind of connected you with Dr. Cross? Was it just the nature of the research that you were in, that you were doing this already? And then we're like, hey, I know the history of, his father being an orthopedic surgeon, actually, and, seeing things with the ACL that have carried over, which I think is awesome and kind of like the second generation of research. But how did you guys, get involved with this? And, were you already doing non-operative care prior to this cross bracing, which I think everybody's seeing the only time that non-operative care is talked about. I actually have connected with Kieran Richardson as well. So I've been chatting with him a bit too, and he's got a little different perspective, which is fun and cool. But, how did this all come about, and how long have you been, looking at non-operative care for ACLs?
Yeah, so since 2011, I've been doing research in this field. And so actually they reached out to me as an ACL injury researcher. So Tom and his team are a large multidisciplinary team. All of them are full-time clinicians. So there were no researchers in the team at the time, and they had clinical data from 16 patients at the time, and they sort of said, "Hey, we want to publish that. Can you how do we go about doing this?" So then I came along and joined the team and designed the analysis and the ethics and ran the analysis and did the research side of things. Whereas Tom has led Tom and his father, the development, the idea around that, and all the clinical practice management and refining the protocol as well over now more than 8 years in clinical practice. We're sort of a merging of the researcher. I'm also a physio, but primarily a research expertise with a team of clinicians.
Yeah, sorry, I just want to jump in. Can you talk about? I'm a big data and analytics guy in corporate America, so I love like good clunky data or cleaning data and stuff like that. So can you talk about as a researcher when you come into this in 2011, which is crazy that it's just hitting the States now in 2020.
Sorry, not. I didn't come into this project in 2011. That was broader non-surgical ACL research.
The topic of non-operative.
Yeah. Even as
absolutely, but not the cross-bracing protocol.
Okay, gotcha.
Yeah. But we can chat about that later, but because there's clinical trials in this space, and I've been doing some exploratory analysis around the Canoon trial as a clinical trial comparing surgery with rehabilitation.
So I guess it's just such a gut reaction here in the States, or a reflexive reaction in the healthcare field to just offer surgery for so many elements. So when you're coming in as a researcher, being exposed to an option that's not surgery, can you talk about like what you're looking for to help a team that calls on you? Like how am I going to structure this? Like what kind of sample size do I need? Like patients, ages, stuff like that.
Yeah. So, this was a little new for me because normally I'll design a robust study prospectively and then consent, and that's the typical way we'll go about it. But in this case, I had clinicians saying, look, we've got this data. Can we publish it? Can we make a study out of it? Which is not the ideal way to go about it because that's retrospective and it's a clinical case series. So that has limitations in terms of the methodology. But understanding the novelty of this and the interest of this to people, we then go and get ethics and write up a research proposal. So this is our research objectives. These are the methods. This is the analysis we're going to perform. And so then I had the ethics as a researcher through a university to consent people retrospectively. So we reach out, we say, hey, we want to run this study. Are you happy for us to use your data that's been collected through clinical practice?
Right.
And 100% of people said yes with that first paper.
Wow.
So that's why it's a consecutive sample. So we did capture the very first 80 people that were treated with this, which is one bonus, because there's other biases that come in when some say yes and some say no, and you can't follow up some. So we did have 100% response rate, which was a benefit. But it is still collected in clinical practice, so it's very pragmatic, and it has other limitations that come along with that too. So we've just received, a bit over 1.7 million in funding to perform a randomized controlled trial, which is the highest quality research, and that's the sort of design you need to compare one treatment with another. So that'll be comparing the cross-bracing protocol to ACL reconstruction.
Right. I just saw an article published that was talking about, 20 and 35 years out, what people are saying quality of life wise, that those that had surgery 20 years out and 35 years out, it was the same group of patients, their outcomes are the same. And I think that of their quality of life. And so Matt and I were talking before, and I feel like that this is the vibe more is, when we're going into talking about non-operative care, it's not that some people won't require surgery. It's just talking the rhetoric that surgery is the only thing that is an option. And that people don't even know non-surgical. So anybody that has reached out to me directly is looking at themselves like, I don't want surgery. What can I do? And thankfully now there's starting to be things, little bits out there where they're seeing it's an option. But, in Australia versus the US, that rhetoric of this is what is needed.
So almost like the culture of healthcare as a whole, Yeah.
Yeah, and we do see that in Australia, which is something we're pushing to change. So there's 3 high quality clinical trials in this area: the Canoon trial and the Compare trial. So they compared early ACL surgery with rehabilitation and optional surgery. So the option was still there to have surgery down the track after trying rehab first. So both of those trials found no benefit of ACL surgery compared to initial rehab and optional delayed surgery. In those trials, around 50% did go on to have delayed surgery. Some of those needed it and others just wanted it. So there were, the Canoon trial did a study where they looked at reasons for crossing over to surgery, and some were because they found rehab boring, because the knee felt good but it didn't feel 100% like it did before injury, because they only entered the trial to bypass the surgical wait list. And then, of course, you have people that do have ongoing instability or signs of instability, and that's a really good indication that you're going to do well or benefit from surgery. So those 2 trials were for acute ACL injury. And then there's a 3rd trial recently published in The Lancet that was performed in the public hospital system in the UK within the NHS. But that trial was quite different from the others because they only included people with long-term ongoing knee instability, so chronic knee instability that hadn't tried rehabilitation previously. And that was, at least, I think, 4 months post-injury, but up to some years post-injury. So this is a group who aren't doing very well, haven't tried rehab, and have ongoing instability. So in that group, they did benefit from surgery compared to rehabilitation in terms of pain, symptoms, and function. So that's quite distinctive. So we can say for people with acute injury, at the moment, the evidence suggests trying rehab first is a good idea. For people with ongoing instability, more long-term, then surgery is likely to be a good option, which we know as physiotherapists and rehab professionals, because we know ongoing instability is a really good indicator that you're going to benefit from surgery.
So on that thought there, when, I feel in the United States, locally, I think globally in the United States, the conversation with orthopedics about this is, thankfully I have a sports medicine doc who, it has heard about this and was willing to sit with me and discuss. And, if I get somebody that's into it, he's with me. We have a radiologist who's curious, who is like, yeah, I see it. I'll report on an MRI that there's a meniscus tear, but the ACL is fine. And the orthopedic will call me and say, hey, they tore their ACL 3 years ago. And he's like, yeah, but it's healed on the MRI. I don't know what to tell you. That's the report. So, when myself or, a client in the United States is kind of looking at tackling going non-operative, rhetorics I've heard already is that, the numbers of the studies are low, or there is a study, I know it's the Sanders paper that they're referring to, showing that surgery is needed and, rehab is not. So, when we're going up against the societal norm with this, right? What I don't know, suggestions, from a researcher, like you have those numbers down, like understanding that, but, do you have any recommendations or suggestions of, going after that as a very, passionate clinician about it? Yeah. And quite frankly, clients who don't want it, to succeed, they're hearing, no, you need surgery. Their friends are saying, no, you need, like everybody's saying, no, you need surgery. And, to kind of fight that rhetoric or provide the evidence, is forcing me to be much more well-read, but I would love your perspective on that.
Yeah. So I guess it's understanding the strengths and weaknesses in particular research methods. So the very best evidence we have is randomized controlled trials that are high quality. And we have 3 of them, if you count we have 3 of them, and 2 for acute ACL injury. So that's the best evidence we have when it comes to rehab versus surgery. And both of them show, similar outcomes on average at 2 years and 5 years. So that's the best evidence we have. Systematic reviews are good, but they're only as good as the study quality that's included in the review.
Right.
So there's a living systematic review comparing treatments recently published in BJSM. including all randomized controlled trials. And the conclusion of those authors is that most people should be trying rehab before considering surgery. That's the best evidence we have at the moment. And I could talk about a lot of assumptions that are made and misconceptions and a lot of beliefs that persist amongst clinicians. For example, that if you want to return to cutting and pivoting sport, that surgery is the best option. That's not supported by evidence. And also the belief that persists that if you go back to sport without surgery, you're more likely to re-injure your knee and you're going to cause further knee damage compared to surgery. That's also not supported by the evidence. But the issue here is there's a lot of really poorly designed studies that have made these clinical recommendations based on flawed research that are saying, you know, the knee's at further risk of harm if you don't have surgery. But there's really key flaws in those research methods that explain those findings.
Yeah.
So I don't think we can expect clinicians or patients, but especially clinicians, you know, without extensive research experience to understand all these nuances in the ACL literature because it is really complex.
Right.
So part of this has driven the reason why we've now developed a patient decision aid that's free and available online. It's at www.aclinjurytreatment.com.
I'll provide it.
And the aim of that decision aid, is to provide a balanced overview of surgery and rehab using the best available evidence so people can make an informed decision. In Australia, we surveyed around 800 patients who've had a recent ACL injury, and we found that most of them receive advice from healthcare advice about treatment options that wasn't supported by the evidence, particularly from surgeons, but also from a lot of physios.
Well, that's what I was going to say is that, you know, when even just the conversations I have, you know, on the more surface level, but just trying to engage people in this conversation. One of my colleagues just went to a big clinic, just like looking operationally, learning new things. And, you know, he mentioned the side and that physical therapist was automatically like, oh no, that's not, you know, surgery is definitely the way to go, but they're also very connected with orthopedics and they're like right within. And, you know, the way our practice is run is it's outside the system a little bit. It's cash based. We don't deal with insurance. We, you know, have this own system going on. So, you know, for me, I think it's important and, you know, a great way to start to get people interested and give them the option for this, because I agree. It's not just orthopedics that are saying, go get surgery. It's athletic trainers, it's physical therapists, and it's, you know, when you read into the research, it's clear that the research doesn't support that you have to have surgery. Like it's not
absolutely.
It's not sugar coated. It's not hidden. It's pretty clear. So, as somebody that maybe would have said that 5, 6, 7 years ago, you know, it's astounding to me, quite frankly, because
in saying that, like it's clear if you know where to look, but then there's a lot of misinformation out there, especially on websites, and especially on US websites, both linked with universities, orthopedic websites in particular, as well as large orthopedic bodies whose job it is to educate surgeons. If you go onto their websites, they say things like, well, pretty much anyone that doesn't have a partial tear should be doing surgery, otherwise you risk serious damage to the knee and ongoing instability, and you shouldn't be returning to sport. And this sort of information's out there, and it says that this is based on research, and it just doesn't reflect the best evidence that's available. So there is so much misinformation out there that I understand where people's beliefs are coming from and why they're still persisting.
Yeah.
Because it's going to take some time to change that, I think.
Yeah.
From our side, PTs don't really, not all, like, but a lot, you know, will read the surface of a research study rather than the depth of it. Right. Like, so you see the abstract come through, you quickly read it. You see there's so much, you know, information, the information overload of sifting through and what is good research and what isn't. You know, we've learned that. I mean, 15, 20 years ago in PT school, learned that, but then, you know, the time, if you're in a busy practice and you're seeing 85, 100 patients a week, to sit and read research is tough.
But these are things that even researchers themselves don't pick up on. You really have to understand the nitty gritty of the methods. Like I can give you a couple examples. So one example is around the return to sport argument. So we're performing a meta-analysis at the moment that's almost going to be submitted for publication. It's in the final stages, comparing return to sport rates between ACL reconstruction and rehab only. And a bit of a spoiler alert, there's no difference in return to sport rates, even at the highest levels.
Yeah.
But if you look into the methods that most studies have used, you have to read really closely to find out, hang on, for the rehab group, they've actually told them that you're not allowed to return to cutting and pivoting sport. And in the surgery group, they were encouraged to. And even still, there was no difference in the rate of return to sport.
Mm.
And another design that's common is they select people for rehab because they don't want to go back to sport. And if they do, they give them surgery. So these sorts of things, that's such an important piece in understanding and interpreting those results, but it's typically overlooked.
Okay, I was going to say this is my data structure question. My question is on these flawed studies. Does the data come out significant and predictive, but when you dig in and look how they structured it, well, you're like, of course it came out significant because you didn't structure it right? Or is it the results are kind of murky?
With return to sport, it's interesting because most of them, like I said, found similar return to sport, even though, there's a massive bias towards surgery because these people have been told not to return and these are encouraged to.
Yeah.
And that's still resulting in similar return to sport rates.
Right.
But that needs to be factored into account because if they were equally encouraged,
it changes everything.
Given the same advice, exactly, it could even be higher in the other group. We don't know, but we need to take that into consideration.
Right.
The other key thing to be aware of around the misbelief that you're more likely to injure your meniscus if you don't have surgery straight away and have additional knee damage, that belief has come from studies that are retrospective reviews of a surgeon's records. And so a surgeon will look at his records and they say, people that come early for surgery have less meniscal damage that people come to see me months or years after an ACL injury. And that means everyone should have early surgery. Now, there's a lot of issues with that sort of design. That group coming to see a surgeon late are a big mixed group. Most of them will have had ongoing instability or an additional instability episode. We don't know if they've received any rehab or what kind of management they've had between that time. And it's absolutely not reflective of everyone that's had rehabilitation.
Right.
In studies that actually do compare rehab with a prospective design to surgery, we're not seeing differences in terms of future knee injuries.
Yeah. Yeah.
That's another example. Yeah.
Yeah.
Can you speak to, so you just got this grant, which is amazing, to compare, surgery versus cross bracing, right? So, I don't know if this is information out yet, but like when you're developing that study to make it, obviously if you're passionate about this and looking at it, like we want to know, like, is there a difference in the groups? Like what is the number to treat on that? Like how many clients are we looking, into for that study? What
will be the sample? Yeah.
What's the sample size? Like, is it going to be determined on, is there going to be, do you have to pick one certain graft? So it's, that it's patellar tendon graft to cross bracing, or does it, put all of them together?
So we're going to recruit 180 people across 4 cities in Australia, 3 states, and have a lot of different recruitment sites through physio clinic, surgeons. So then they'll be randomized to either the cross bracing protocol within 3 weeks of injury, ideally within 2 weeks, or early surgery. And the surgery will be performed within 6 weeks. And if they're randomized to surgery, that will be more pragmatic. So the surgeon will do the procedure they usually do. These are top surgeons, so they're very experienced and popular surgeons that will be doing the procedure, and then they'd undergo their usual post-operative rehab in that arm. And with the cross-bracing protocol, we're standardizing that and making sure the physios delivering it have done the training, and we're collecting a lot of outcomes in both groups as we go. The primary outcome will be collected at 18 months. That's the primary endpoint, with the primary being the COOS-4, so pain, symptoms, sport and recreational function, and quality of life. 18 months is important because we want to account for the fact that some people will have delayed surgery in both arms. so even within the ACL group, some people will have re-injuries, but we want to allow at least 12 months for most people to recover from that surgery. So one of the limitations with other trials is they've included people that have had ACL surgery, 4 months before the primary endpoint. So if someone's 4 months post-op, of course they're going to have a lot of pain and swelling, and that's going to drive the whole mean score down for that group. But that's not really reflective of the outcome we're interested in, which is once that acute impacts of surgery has come down, we want to look more at the longer term comparison in outcomes.
So are you able to blind that study or not really?
You can't. Yeah, no, you can't.
Right?
Yeah,
Like,
you can't blind someone.
This is your choice, and you have to do this.
Yeah.
Like you can't really.
Double blind study humor. I like it.
You can't. Right?
I mean,
right.
Yeah, you can blind assessors, for any assessments and the statisticians, but no, you can't blind patients with this kind of study.
Yeah.
Like you're not, it's not like a trick inside there to get that done. It just is what it is for that type of study.
Yeah. I mean, I think a dream study would be a blinded placebo ACL surgery study. But in terms of how you do that, I don't think it would be very ethical, because
I was going to say, how's the ethics committee on that one? Not good.
Well, there are a lot of, there's meniscal placebo blinded surgical studies which have shown no benefit in meniscus surgery compared to placebo. But what they normally do in those surgical studies is they replicate, so they'll remove the one part that they think is meant to be working in the surgery, which in this case might be the graft. But to mimic the other effects of the surgery, they'd likely have to drill into the bone and do the drill hole. And that to me doesn't seem ethical,
Right.
Yeah, because if they wake up from surgery and their knee feels great, they're going to know which group they were in.
Right.
So that's the concern here.
And you said this study for 180 people, I think. Is this the 1.7 million you got the grant for?
Yep.
Yeah. So there's layman for our patients, our Gen Pop. Like, does that go far? Like, are you confident that budget can stretch, or is that like you're kind of not working with as much as you'd want? You know what I mean?
There's never enough money for research.
Yeah.
And there's a few issues in Australia around personnel. Having the staff that you need and the money to pay the salaries you need to do the research.
Right.
But, it's revolved around a budget, so we know this is the money we need to conduct this.
Yep.
There's no spare money. There's no leftover.
Right.
You can't say, actually,
it's very tight.
250 people. We wouldn't be able to fund that.
Right.
But it's still a substantial bit of money, and it reflects that this is a priority for the government and a lot of stakeholders here. In Australia, we've got a lot of research partners. The private health insurers are on board and providing money.
Yeah.
The physio bodies, a charity that looks after children's health. Yeah. So other partners that are really interested in this research are putting cash in as well towards the study.
Yeah. Are you confident? Sorry to go macro here for a minute, but like, are you confident like in the culture of healthcare, like how people are funded, the changing the culture? Offering this new research versus the States, which has become surgery and big pharma, dependent. Is that culture like good down there to bring something like this to market, where the Gen Pop, somebody like me that comes into office, can be informed, and I'm getting that up front from providers, versus going on Google and I'm a patient in Georgia finding Allison in New York State, 6, 7, 8, 10 hours away. Is Australia do you, from your perspective, like, receptive to these types of things?
So the way I see it, at the top of the table in terms of acceptability with evidence and non-surgical treatments is like Scandinavia. They're really leading the way and have been for decades.
Yeah.
Australia, we have divide amongst physios. We're working with a bunch of surgeons on the trial who are terrific, and they're really open-minded and they give great evidence and advice to patients.
Yeah.
It is probably, unfortunately, the minority of surgeons based on our recent study, but it still exists and it's growing proportion. So we do have a mixed bag.
Yeah.
I think the US has a long way to go, and there's a lot more financial interests and other things, commercial interests driving the lack of change in the US compared to in a lot of other places, unfortunately.
Yeah.
But the patients are speaking out and they want more options and they want non-surgical options. So I am contacted by so many Americans that are saying, I'm based in this state, please help me. Who can I see? A physio,
Wow.
a doctor, a
Yeah.
surgeon. And, we've got Alison in New York, but, we do need more advocates for not only rehabilitation, but for a balanced approach, for weighing up both treatment options. And feel free to reach out, if you're a physical therapist or a sports doc or someone else that has been active in this space. Because I can jot down your name in a particular state and send some people your way, because we just don't, well, I don't know about who out there is offering more of a balanced approach in terms of treatment options around this. So unfortunately, I think the US will be the last to see substantial change. Yeah. But if the rest of the world has got high quality evidence, they're going to have to adopt some of that at some stage.
I just think we're seeing, and certainly it can be the circles we're in, it's just the consumer-based care is becoming more regular, right? So again, PT for us, we're 95 or higher percent consumer driven. We're not driven by physician referrals right now, where if we were an in-network clinic, that would be 50 to 60% would be driven by physician referrals. People are, there is more functional medicine, there is more small bits, but even in my little area, more concierge type primary cares. So I think that's what, to me, the message is, or to people I know the message is, and I just kind of won't shut up about it, is that, you have a choice, and it doesn't have to be for anything, hip labrum surgeries, any type of surgery. Like, if you don't want it, then why not try without it? To me, that's beyond the ACL piece too. But obviously working in the ACL scope is a passion of mine, but like anything, like if you don't feel like that's what's right for you. I mean, the one gentleman I have that found me via this podcast, in one episode where we spoke about cross bracing, reached out, and we're working through cross bracing. We've been, working through it from a telehealth side. And he's just like, this aligns with my values, that the body can heal itself. So giving that perspective and that freedom back to people's mind, I think, is a big thing for me, and a big preach for me is that if it aligns with what you want, if you don't want a cortisone injection, you don't have to have one. Let's find other ways.
And you will always have the option of having surgery. That option isn't taken away.
Yeah.
You're not at any risk except for inconvenience and potentially adding time on if you go and have surgery later.
Right.
As long as you've got appropriate healthcare providers that are supervising to make sure. What we don't want is a chronically unstable knee that's giving way and causing multiple further damages. Yeah. But if at the first giving way episode you go and have surgery, that doesn't result in worse outcomes than if you had surgery straight away. Yep. So you still have surgery as an option. So that's the main thing here. And I think with a lot of orthopedic surgeries, I've had other injuries as well where I've been recommended other joint reconstructions, and aligning with my values, I see a good role in those surgeries, but I'm absolutely going to give non-surgical management a go first. And if I don't achieve the function I need and desire, which is high level of function, then I'll go and talk to a surgeon. But I'm going to try another option first. That's my own personal values. And there's a lot of people, like you say, that share those values. And to say to someone like that, oh, no, sorry, you have to have surgery or you're going to have arthritis in 10 years' time and you're not going to be able to play with your kids and you're only going to be able to run in straight lines. To scare someone like that into surgery, as in that the best option for them is, it overrides informed consent in healthcare, really.
Yeah. One of the biggest red pills Allison fed me in this podcast that we did an episode on nocebos and just like how that language is offered, and sometimes even the dismissiveness of there is option A, there is no B, there is no C, or you're rolling the dice if you even try those. So it's encouraging to see that regardless of the divide, it seems like it's kind of growing down there at an I don't want to say acceptable rate, but relatively acceptable rate where meaningful change can kind of be implemented faster than other parts of the world.
Yeah, I think so. And people often say to me, how are you going to change all surgeons practice, And I say, well, I think we can start by informing physiotherapists. I think, if we can't inform physios about the evidence and giving accurate advice to patients about their treatment options, then, we have no hope in changing surgeons' opinions, or some surgeons, that is. But I think the physio profession or physical therapists in the US have a big role to play. They are rehabilitation professionals. It's not ethical to say that everyone will have great outcomes or better outcomes with rehab, because that's not true. It's acknowledging the evidence we have and what that tells us, the pros and cons of each treatment pathway, what those pathways are going to involve, their treatment options, down the track. What will happen if you have ACL surgery but you tear your graft? What position are you in then? We know that's a risk factor for really poor outcomes at that stage. Revision surgeries don't do very well. They're associated with a really poor prognosis. What happens if I have rehab, but my knee gives way and it doesn't become stable, after, say, 3 months of rehab? What happens then? Okay, well, then at that point, at the first sign of that, we're going to, refer you to a surgeon, and likely surgery is going to be a really good option for you, because you haven't regained the function and stability that we want. So really explaining those pathways, the pros and cons of each, which, we could discuss for ages, as well as the available evidence and what that shows, which is similar outcomes on average. So,
And Elle, like you've talked to me about specifically with cross brace, like, is it still the evidence showing that, again, I don't want to mix my language, but you've got to kind of catch this relatively early in the process to kind of implement and get them on that track where they can wait 3 months. Is that still where you guys are at with that?
Yeah. So in terms of the brace, we're thinking earlier the better, after the first 4 days, because you wouldn't want to brace too early while there's still a lot of swelling and inflammation. So likely no longer than 3 weeks.
3 weeks.
Of course, there's exceptions, but to benefit from the mobilization of the brace, we think it should definitely be within the first 3 weeks, ideally within the first 2 weeks. But in saying that, in our recent study within the Canoon trial, at least 30% healed with early rehabilitation. So various different grades of healing, but they had a continuous ACL at 2 years after doing rehab. So it does. That's not to say that, someone won't have a healing outcome if they haven't worn a brace, but it's just that to undergo that, quite time consuming and inconvenient being in the brace, we're probably not likely to benefit from that additional immobilization to bring the ends closer together if you've waited that long. Because in a lot of cases, we're already starting to see more changes in the ligaments. So sometimes the ligaments retracted or starting to round over and involute or cap over, which might be a sign that healing's not going to occur, and you're probably not going to benefit from the brace at that stage. So but we don't have a lot of science around it yet. It's based on experience. So we do need more research to understand this. It's not black and white. You know?
And that's like, I'm just, with talking again to you guys and talking to Kieran, and it's just, there's, seemingly somebody that's not involved with research, there is a wide scope of bracing. The cross bracing protocol is just one protocol right now that can be followed. And in my thoughts, it's like, in order to research it, you can't just be like, oh, you could brace from 90 to 20. You could brace from 90. You got to have more of a concrete protocol that then might change over time. Right. And then can go into what the protocol looks like, just, I mean, on the surface, I think if people are listening and interested in it, they might have researched it a little bit already, but what does the protocol look like as it stands as the cross bracing protocol? And what's the goal? Like all those things that I can sort of talk about, but you're here, so we want to hear.
Okay. Yeah, sure. Okay. So yes. So the theory around the cross bracing protocol is that by immobilizing the knee in a position where the two torn ends of the ACL are closest together, which is 90 degrees and greater of flexion, but it's not very practical to brace at 110 degrees flexion. So previous braces are typically in extension or only a slight bit of flexion. So this was the first protocol to try 90 degrees, so more deeper flexion and mobilization. And so the theory is that by mobilizing the two ends of the ligament closer together, that it might facilitate a bridge of connective tissue between the two ton ends and subsequent healing. That people have attributed the gap between the ruptured ends to a potential inhibitor to healing. So doing this early aggressive rehab, where the ends of the ACL are moving around and the knee motion, could actually inhibit healing. So that was the hypothesis. So for the first 4 weeks, then someone is braced within a knee brace that's locked at 90 degrees flexion, and they wear that brace for 24 hours a day for showering, for sleeping. And so they need quite a bit of education and strategies around, how to do ADLs and how to mobilize and other things. But they're not inactive during that time. They're doing a lot of rehab, both within the brace, even in terms of isometric quads, hamstring contractions, wall squats with your knee at 90 degrees, bridging, other activities that you can get into with the actual quads and hamstrings themselves, but also the hips, calves. You're doing the contralateral side, you're doing cardiovascular exercise. So rehab begins on day 1. You're not immobile, so that's important. So then at week 5 to 6, the brace is adjusted to allow 60 to 90 degrees of motion. And from then onwards, at weekly increments, the physio adjusts the brace. So it becomes a bit easier because they're seeing a lot of progress in terms of their range, and they've got more range to work within the brace with their knee in terms of their rehab exercises. So week 5 is 60 to 90, week 6 is 45 to 90. And then by week 7, they've got full flexion allowed in the brace, but it's locked at 30 degrees, so 30 to full flexion. Week 8 is 20 to full flexion. Week 9 is 10 to full flexion. And then by week 10 in the brace, they've got full range of motion allowed. And so then they've got full range in the brace, and then the brace is taken off at 12 weeks. So that's the actual brace adjustment. And then there's different rehab goals and progressions. They get more and more difficult throughout at the same time as well. So they're doing quite a lot of strength training, balance, proprioception during that time.
So it's I was getting during those first really 6 weeks, they're navigating around non-weight bearing, but that's mostly because they can't get their foot to the floor because they're braced. So, a lot of people that I have talked to, again, just through this was, it says non-weight bearing, but it says to do wall squats. And I'm like, it's not a non-weight bearing protocol. It's just, you're not going to get your foot to the ground when your knee's bent to 90.
Exactly. And that's just because of safety. They're more likely to fall over, right? If they're trying to put weight through their foot whilst walking on crutches. So and I've changed that to clarify that was referring to whilst on crutches, but we're actually trying to take weight. We can do that as physical therapists, physios, quite creatively within that available range. How can we take some weight through that leg? Because it's the range of motion that we're trying to maintain to facilitate the healing. It's not non-weight bearing. In fact, there may be benefits to taking some weight through the leg and to doing that in different ways. You could, even standing at 90, you can be putting the foot against the wall and pushing through, taking weight through your leg and through your hips. So there's exercises and things that you can be doing. It's not no weight going through the limb. It's just a bit.
Everybody turns to fear of non-weight bearing, and then they're like, "What? No, I can't." I'm like, "It's not a fractured bone. Like it's it's exactly the position." And then the other major question I had behind it is, so right now, per the protocol, at around 12 weeks, everybody is recommended to get MRI'd to show or to show progress of healing or not.
Oh, 12 weeks. Yeah. I mean, patients want to see.
Sorry.
Yeah, no, sorry. I thought you might have meant baseline MRI.
Got it.
But you mean, after the brace comes off. Yeah, I mean, is it necessary? Probably not, because the most important driver is someone's function. Yeah. If it's stable and they're functioning, do we need to see what's going on? No, but patients want to see that, and they want to see, I mean, historically, there's similar outcomes with rehab and surgery. That hasn't been considering the healing status at all. So that's a mixed bag of people with rehab. We don't know what proportion of those all along had a healed ACL or didn't. Right. But historically, we assumed it was muscular the muscles were accommodating an ACL deficient knee. That's how we used to view rehab.
I want to
Now
go
we know
back and
for some,
MRI like so many people.
exactly.
I've had non-operative rehab, and I'm like,
Yeah.
oh, you are just a coper. You're doing great. You have no ACL. You're doing fine.
Exactly.
And I'm like, I want to know. I'm like, did you heal? So yeah, I guess that's a big question is, obviously for the research to show it you need that data, but yeah, because what happens to somebody's mindset if, I guess a twofold question. One would be when they're re-MRI'd, I'm assuming there is a wide variety of what you would see for healing. So I've seen some or is it very classic? Like I've seen a few where it was like the hourglass was starting, like you could see the cross bridges happening. Is there other, variations you might see, or is that the one that you're looking for if you're re-MRI'd? And I guess on the flip side, the psyche behind that, to your point, like what if we did this 12-week thing and there isn't any healing of the ACL, but they feel fine and then they're progressing fine? Like how does that shift? So.
Exactly. And when we say feel fine, a functional stability is the most important. And I don't think people are usually pretty active if they've done their ACL. I don't really think it's saying, well, hey, your knee's unstable in sports, so just don't do any of these activities for the rest of your life and you'll be fine, avoiding that. I don't think that's a great outcome. It's either the knee's stable in cutting and pivoting and activities, or it isn't. And if it's unstable, as in it's giving way, then surgery is likely a good option. If someone really doesn't want surgery, that's of course still their choice, but they need to know the risk.
Yeah.
If the knee is giving way or further knee damage and arthritis and other things. So that's an outcome that we don't want. It can change over time. They may want to wait a bit more long term to see how the knee's going. But again, we don't want to wait if it means 5 giving way episodes, because you're probably going to injure your meniscus and you're going to be at high risk of, of arthritis in the future.
Yeah.
So, sorry, what was your...
So I guess
question?
so clinically based, like if somebody, because a lot of people, as again, those that I've been exposed to, which the number is much smaller than what you have, those people who want that MRI but are stable, like let's say they're getting there and they're stable. Like to your point, like, do we care if it's healing or not? So that's what.
That's right. Yeah. Sorry about the variations in healing as well. Yeah. So
yes, and the variations in healing was the other question. Yep.
Yeah. Great. So we know what an ideal heel looks like, even by 3 months. So it's taut, so it has normal alignment, and around 3 months, it's likely looking thicker than a normal ACL, but that will change over time to just appear as if it was never injured. So yes. So that would, like on the ACLOS scale, which is one scale that you can use to grade signs of healing, there'll be a grade 1 and likely progress into a grade 2, a normal appearance ACL. So that's great. We think that functions really well. People are reporting
and you can
excellent
see
outcomes.
that at 12 weeks. Like you would see that thickening, almost like a bony callus that you're seeing around it. It would be bigger than typical.
Yeah, it's more about what you're not seeing, which is the other signs, which is thinner, right? It's whether it's really thin along a particular portion, or the whole ligament's looking very thin by 12 weeks, or it's elongated. So you could describe that as a bit of a sag, or it could look kind of loose, or it could be a little bit elongated, so it's got a little bit of a curve instead of being quite taut. So that's an interesting group. It's people that, yes, it's healed to some degree because it was discontinuous and now it's continuous. So the fibers are rejoined, but they're thinner, or they look looser, or they have a bit of a sag. So I think that's a fairly mixed bag in terms of function. Some of those people function great and can return to sport, and others don't and will likely benefit from surgery. We need to consider that a graft isn't a perfect fix. It's not the native ACL. A lot of grafts themselves don't take up, or ligamentization, or have other issues. So if we think about a graft having mixed results, a lot of people do really well, but some grafts aren't great. And then this other signs of healing. We don't yet know how that group compares with a graft on average, but we do know that it's a bit more of a mixed result. So I don't think we should be saying, oh, your ACL looks a bit thinner, so you've had a poor outcome and you need surgery, even though they've got really good function up to that point.
Right.
We do need more research, though. We need to understand re-injury risks.
Yeah.
You know, if it's thinner, is it more likely to re-tear in the long run? We don't know yet. Yeah, so we need a lot more research around that more mixed signs of healing where it's a bit of elongated or a bit thinner. But yeah, I mean, within that Canoon paper, within the first 80, that group who had a thinned or elongated were reporting excellent patient-reported outcomes, and 64% of them had to return to their sport, which is around the percentage we see after surgery. And their PROMs, in terms of their pain and function and symptoms, were in an excellent range on the Lisham scale. Now, we need other research designs, but I just think we've got to be cautious not to assume that that's a poor outcome for everyone at this stage.
Right. So where did the ACL take this hard shift, right? Because like the anterior talofibular ligament, you know, somebody could have a very this on the ankle, an ankle ligament could have a very positive laxity sign and be totally fine functioning. Now they probably have sprained their ankle a few times, but again, we know like if we, again, from the rehab side, give them some great proprioceptive input, get them strong, like, and you know, gradually get them back to what they want. A lot of people can do great without reconstructive ankle surgery. Like where I feel like that is more widely accepted than like where did ACL take this hard pivot to surgery? When did that
happen? You look historically, back in the early studies, and it's actually very similar to ACL injuries in dogs. It's the same thing that happened. If you look back, it's always based on observations of people doing very poorly. So if I'm a doctor or a surgeon and some people come to see me having had an ACL injury and their knee's extremely unstable or they've developed really aggressive arthritis, I'm therefore going to say, we need an option, you know, or we need surgery to fix this. But what we don't know is what proportion of people was represented by those people occurring with extreme outcomes or really poor outcomes. How many people actually were fine? Because it was based on the observations of people that weren't doing well. And that's a lot of different areas, including ACL injury, of how it's a little bit backwards in the beginning. You know, in an ideal world, you'd then say, okay, we need longitudinal cohort studies where we look at people who have had ACL injuries and see what proportion are doing poorly and what proportion are doing well. But those early studies don't exist. It's then jumping straight into surgical and more invasive treatments to try to improve outcomes for those people. And in a way, they've succeeded because they are improving outcomes for that proportion that had that extreme poor outcome, the unknown proportion, shall we say. But does that mean that everyone needs surgery? No, it doesn't. So, yeah, that's sort of where it came from initially.
Yeah, that makes sense. Right? It's just odd. Like, think so many other ligaments. Like, it's just, yes, sometimes there's surgery, but it's just non-operative is much more accepted.
It's really similar for other joints, though, right? So I recently had a shoulder injury, shoulder dislocation, severe labral tear, 2 fractures, the Hill-Sachs fracture, vein cut lesion, bicep femoris tear. Anyway, and I was told, you need a shoulder reconstruction. You know, no, the evidence is really strong when it comes to this. You're going to have poor outcomes if you don't. You know, you'll really benefit from a shoulder reconstruction. And I said, okay. And I had a bit of a look at the evidence and I said, oh, yeah, it's not as strong as what I've been made out to believe. So, but I get that surgery is quite successful for people that have chronic instability. But this was the first dislocation I've ever had. So, of course, I said, well, I'm going to see if it can heal itself first and if I can have a stable shoulder before considering surgery. Anyway, it's been about only 6 months now and I've returned to sport. So far, so good. Now I'm asymptomatic and I've got full function. Let's see if I have another dislocation episode. And you know what? If I do at that stage, then I'll go and talk to a surgeon. Right. But for me to jump into a surgery that involves, you know, removing a bit of my scapula and screwing it into the front of the shoulder, and it just doesn't make sense to me without trying.
You're jumping right to a ladder J for your first time dislocation. Holy
Yeah,
moly.
well, it was quite severe, as a very severe labral tear, which I was told will not heal. It's
Sure.
not going to heal, because of that. But so far, I would describe it as having healed, certainly symptomatically. So let's see and stay tuned. But I think there's a lot of other orthopedic procedures that we could likely challenge in terms of the way we view the necessity that goes straight to surgery for some of these
Correct.
things.
Yeah.
Correct.
Yeah.
Correct.
The wrong patient walked into that doctor's office. They didn't know what they were getting. They're like, yeah, no, you're incorrect, sir. So
No, I just took the nod and smile approach. Yeah, we'll see.
Right. We're not
It's
going
not
there.
it's not likely gonna happen. We'll see. Yeah, we'll
So
see
like,
how we go.
but like a case like that, right? So like, maybe you will because of the seat you sit in, but that's my thing is like a lot of people that we see that re-tear or have a second ACL, they don't go, maybe if they have their other side done, they might go back to the same surgeon. But a lot of times, and I guess like for people I see, it's probably 50-50 anecdotally that, if they re-tear the same graft, oftentimes they're trying to change the next time. So they're changing surgeons or, changing PTs. And so you don't, like the surgeons don't see, or the PTs they were with don't see this negative side of it. And, I think that's something like, I see. So they're thinking it's needed, or they're thinking like everything is going well because now they haven't seen this person, but little did they know they retore. And
absolutely. Yeah, it's that people that they're seeing that aligns with, when people walk through the door, I injured my ACL 2 years ago, I didn't do anything. Oh, your knee looks terrible. This means everyone must have early surgery. It's similar, right? If they're not seeing the negative outcomes or the long-term outcomes, these people aren't coming back to them with arthritis in 10 years' time or with a graft rupture and an unstable knee or even persistent swelling and inflammation that never comes down. Often they don't go back and see the surgeon. So, yeah, I mean, research is the best thing we have to go by there, obviously. So, to sort of inform long-term outcomes, but it would help people clinically to understand how people go in the long run as well.
Right. Or people that have a successful non-operative outcome to go back and say, hey, I did, when people like are being forced that direction and they're on the consumer side saying, I don't want it, and then they might like end up in rehab and do really well. They're like, I'm like, well, how are you going to let your surgeon, how are you going to let that orthopedic know that you did well? Like, it's just sometimes that knowledge behind it, right? Like if we see somebody, and again, I'm not saying we're perfect either, but if see somebody and that knee isn't getting stable, like, okay, well, you're not stable. Let's go for surgery. But if surgery is your thing and you don't see the negative outcomes, why would you change your practice? Is my too.
Yeah, and I don't think there's always going to be enough surgeries to perform. I don't think we're putting surgeons out of business here.
For sure.
And I think there's also some early signs around the severity of the ACL tear. So the more severely disrupted ACL may be a really good option for an early surgery. We need more evidence to show that. So exactly what signs on early MRI will indicate that this person's going to benefit from surgery. But there's some preliminary findings suggesting that might come, in terms of research in the next year or two. We might start to understand that a bit better. So we're not suggesting no one will benefit from surgery.
For sure.
Just that I think that's not everyone needs it,
Right. And I do feel like that's anybody, any healthcare provider or individual gets onto the defense. Like, what? You don't think anybody needs? No, like that's not what I said. I'm just saying there's another option and leaning into that, try for 3 months, especially kids, that like, what are we doing? Why are we jumping to surgery? Like they're under the gun to get back to their youth sports and why? Like just, if we're talking 3 months and you might be doing really well and you could save yourself that. But definitely that culture of the immediate fix isn't just ACL world, right? Like that's everything. Like I want it done now. I want to be back as fast as possible. I want to do it now.
And it is pushed down from the elite level. We watch sports stars on television, the commentators say, done their ACL, they're going in tomorrow to get it fixed and or another injury, right? That's the mentality. They go and have surgery straight away, whether that's the right decision or not. That's what they do at that level. And that filters down to recreational sport, to kids, to parents watching television in terms of the mentality. If they're having it, it must be the best treatment option.
Yeah, we hit on that last episode. Yeah.
Oh, you did? Okay, great.
Let's go. Let's just like, I know we're a little over our time here, but let's just say, like, for anybody listening who is listening to this because they recently tore their ACL, the process, and we've gone through this a little bit, but the process to determine if you're a candidate or not, I know you guys have the online tool, which is amazing, but, people like timeliness of MRIs, how do we navigate that as a consumer who has torn their ACL or been told they tore their ACL and they're already looking at options, but they haven't had their MRI yet. They haven't met with the orthopedic yet. Like, what do they do? What are your recommendations for somebody to,
Yeah. So get an early MRI is first step. I wouldn't normally recommend MRIs, quick MRIs, but when it comes to the ACL, it is important. The Australian government understands that, and they fund acute MRIs for a suspected ACL injury because they know misdiagnosis can cause further damage and can be harmful in terms of arthritis risk and other stuff. Because so that is often misdiagnosed.
That will not happen.
Okay. Yeah, no. Which is it's a shame, but it is important because of that. A lot of people might be told, oh, hey, you have a MCL injury and it's just rather minor, and they push through rehab and they're improving, and then they go back and try in the sporting field and their knee grossly gives way, and then they get an MRI and it was their ACL. Like, that's quite a common story in terms of misdiagnosis. We are starting to question, pivot shift test or an aggressive Lockman, especially a pivot shift. So that's recommended, and part of diagnosis, both pitch side and the sporting arena, but when you go and see a clinician. It's a very aggressive test, and the mechanism of pivot shift is mimicking the mechanism of rupturing your ACL. So let's say you had a high-grade partial tear. Or let's say your ACL was starting to heal, and this is a week or two post-injury. And then a clinician does an aggressive pivot shift. Clunk, your knee swells up, it's quite sore. What's that going to do to a potentially healing ACL or a high-grade partial rupture that might have had a really good healing potential? So I think that could be actually quite harmful in terms of someone's outcome. It's usually the first thing a surgeon will do. Not saying that they've got any bad intentions, because it's recommended practice.
I mean, I would do that. I would
exactly.
Do that, right?
Yeah, it's absolutely recommended. But now that we know about healing, which is more of a recent discovery in a way, I think we may need to flip this on its head in terms of how we treat acute ACL. Does this ACL have potential for healing or a high potential for healing? Let's protect the ACL from further trauma whilst we get an MRI and have a look. What's it look like? Is it severely disrupted where it's pulled off the bone, or is there any fractures, or is it really displaced or like shredded in terms of the ends and a really big gap between the two ends? We may find that those ACLs will benefit from surgery the most. That there's a whole spectrum of injury, some with where the ends are quite close together, or there's just a tiny bit of fibers possibly intact, and they're likely to have the highest healing potential if the more minimally injured, still fully ruptured, or high-grade partial, those sorts of things. So flipping the way we think about it to think, okay, first thing, let's look at this person's healing potential once we have the evidence to really inform those decisions. Let's protect this knee whilst we wait, and hopefully we have great surgeons that we can work with that understand the different treatment options too. And so they have a really informed decision about the different treatment options. And some of them might say, well, hey, let's try rehab only first, or let's try the brace if I'm a decent candidate for that. And then I'm going to reassess in 3 months' time and see whether I think surgery is needed. Like, maybe that's my decision.
Yeah.
Or maybe, I've thought about this and I don't want to, if I do 3 months and then I'm told I need surgery, that's really going to affect me mentally. Like, I'd be happy if I just went straight for surgery. My brother's had surgery. He did great. Like, I really, for some people that will be their decision and their preference as well. But it's weighing up those pros and cons.
You're putting yourself in the consumer shoes. Like, what do they want? And it goes back to the values you were talking about. So somebody, again, like me, Gen Pop, will feel more in control of the decisions we make, right? I mean, that's
Yeah, but
giving
they
them
can
that
only
freedom.
know what they want if they receive accurate information. That's the
I know.
thing here, where most people aren't. So it's
Yep.
I think it was in Kieran's lecture, but he was talking about like elite PT, like this term of elite PT, and like what does that mean? And to me, that's like elite healthcare. And to me, the number one, we were talking about it with the clinicians I work with, and like let's define that. Like what does that like elite PT mean or elite care? And the number one thing is that it's patient centered. It's what does the patient want first? It's not what I want. It's not my bias. It's not what I feel like I'm good at. It's what's important to you and what does that look like? And then we'll help you make what's possibly the best decision for you. And then obviously there's other things with the care, but to me, that's number one of what do you want? And I don't think that's certainly in the States that's put in our hands enough, or at all often. So.
Yeah, that's a shared decision-making model, really, isn't it? But the crucial bit of that is that accurate evidence, balanced evidence, and then making the decision that aligns with their values and their preferences. But without that first important, missing piece of information, then people will draw upon their misconceptions or their preconceptions around treatment options, which usually is surgery's the best. Surgery's a fix. It's quite quick and easy. People say it's like going to the dentist, they're just going to go in there and fix or repair my ACL. Often people's understanding of what actually goes on in terms of removing their ACL and etc. is quite surface level as well. So, it's having an accurate understanding about what each treatment pathway would involve and the intensity of rehab engagement in each treatment pathway. Post-op rehab is also really important.
Yeah, right.
So having that understanding.
I was just going to say, like the quality of rehab, how much does that weigh in on, if does that override almost whatever path you choose? If you get, the best treatment and strength training, during and after surgery or during cross phase, if you're training right and comprehensively, does that kind of negate the decision and make it moot, or is it still showing no matter what? There's some evidence that one option might be on average, better than the other.
So there's no evidence that one's better than the other.
Yeah.
On average, there's pros and cons.
Got it.
Of each.
Yeah.
Even the common belief that if you're older with a low activity level, then you should have non-surgical management. But if you're young and want to go back to sport, then surgery is the way to go. I think a lot of clinicians have that belief as well, that age and activity level. There's no evidence to support that. Yeah. In fact, we know that young people who return to sport after surgery are at highest risk of re-rupture and then double revision, re-rupture again.
Wow.
So they're both risk factors, younger age and returning to sport post-surgery for re-rupture. So that's something else we need to factor in if someone's young. We really want to avoid that. We want to avoid being in a position of having a graft rupture. That's, there's a lot of literature showing that that's associated with poor outcomes. So,
I mean, the rehab is, I think, from a research side, hard to quantify because you're not doing the same thing with everybody, right? So it's more of the type of rehab you're getting is it patient-centered? Is it, obviously there's focus on the quads and obviously there's measures that we know that we can take that are showing to be important. Quad strength, looking at symmetry between the sides. And although it's not like perfect research either, there's, in my opinion, enough to say we should at least be looking at this stuff. And so like if we're not looking at that, at certain parts about symmetry and quad strength, I mean, I have people all the time that are coming either after a re-rupture in a second surgery, or they just can't return after reconstruction with the stable knee and they don't have the sufficient muscle. Am I a doctor of PT? I am. And they don't have the specific, muscular strength to support their knee. Like, of course it doesn't feel good. Like you can see why it doesn't. So I think the variation in physical therapy and rehab is so wide that it makes that a hard, I don't think it makes it a hard conversation, but a lot of people aren't doing well because they don't have the musculature to support a stable knee.
Yeah. In both treatment arms, it's true. I mean, as long as it's goal orientated and not the odd time-based approach, which some people probably still do. By 12 months, you can return to sport. Doesn't matter about your functional strength.
6
So
months.
having goal-based
I need
progression.
6 months. But yeah.
Oh, really?
Oh my God, all the orthopedics are 6 months by me. Still.
Wow.
It's tough.
Okay.
It's tough. It's tough from the psychological side. It's tough to push them off because they'll get medical clearance. And I'm like, it's really hard conversations to have because people are itching to go. And and then, some of the rhetoric as well, the research behind, having, the numbers in the research article, this is what I've personally heard, don't necessarily support that we need to wait, or one that the quad strength doesn't matter. Like, okay. Like,
you'll find probably a study to support any opinion if you don't consider the quality of that research, and that's where it can be very misleading. I mean, there's multiple studies showing that passing return to sport criteria reduces the risk of re-rupture.
Yes.
Which makes sense, but that's typically hop function, strength testing, some kind of psychological measure in terms of readiness to return to sport. So that stuff matters. And then there's the biological considerations of the graft and where that's at in terms of its healing post-surgery. So, there's systematic reviews showing that returning to sport before 9 months is associated with higher risk of re-rupture.
Significant. Like not by a little bit, like 38% or something huge, right?
Of course,
and every month after that, it goes down. And looking at that, and then we are like literally still telling people that 6 months is the time frame is just fascinating to me. So
I think, sitting people down and let's look at what this might mean for you if you're going to tear your graft. Because hey, if I just want to get back to football, I don't care. What's that re-injury? I'll deal with that if that happens. Just get me back as quickly as possible. Hang on a minute. Like, if you tear this graft, this is going to be your options. You have this likelihood of having persistent pain for the rest of your life. This likely to have arthritis. It's going to be painful and debilitating in terms of your function and what you can do for the rest of your life. Your quality of life is going to be a lot poorer than after a first ACL. Sitting down and discussing that, I think, is important, because that's what we're really looking at here, is the risk of re-rupture when it comes to returning to sport too early.
Yeah,
for sure.
Yeah,
awesome. You've done a fabulous job of hitting kind of all the points I wanted to get to tonight. Is there anything that we haven't touched on, whether it's bracing or non-operative or ACL in general, that you feel is important kind of for general population or clinicians, to realize? And I think we talk a lot about just become curious about, right? Like, dig deeper into challenging the norm. Hopefully some of that, that curiosity side.
Yeah, I think that's really important. You can't take, especially things you read online or on a website, at face value, especially when it comes to ACL injury. A lot of that information is incorrect and inaccurate.
Right.
So you do have to have your investigator skills on and to be thinking critically about what it is you're reading. Thinking critically about research articles. Go straight to the methods section. How are these people recruited? Who are these people? What were they told? What treatments did they receive? Don't go straight to the results or the abstract or the conclusion. So think methods first. And if the methods are shocking, chuck the paper out. Don't even read the conclusion. So we need to start to think critically about research, especially in this area, because there is so much poor research and misinformation out there. So I think that's a really good point.
So important.
Yeah, I will just add one final comment. So we haven't covered it in terms of the bracing protocol. Just the importance of DVT prophylactics and prevention. So we don't want sort of physios chucking braces on people at 90 degrees without considering medical side of things. including DVT risk. Could they have a current DVT? Are they at high risk of DVT? So like contraceptive pill use and other things. So you do need that medical oversight to make sure that that DVT risk especially is managed. So that's important from a safety point of view.
That is probably one of the greater barriers I've faced is people who have been wanting to do it, finding somebody that will support that in prescribing it. It's, you know, like when people are going here to physicians to prescribe, like with the intent of this is the protocol. This is why Dr. Cross has even written, you know, some stuff up for me to give to them for the physicians to read of why, like the reasons behind why that was put into the protocol. I've had two people who point blank, the physicians, primary cares, orthopedics are like, nope, we won't give you that medicine. And so they're running into that. That is a major barrier right now for us, you know, for what we're doing. Because again, if people are local with me, my sports medicine doc that I work with would be open to it, meeting with that, categorizing their risk and working through them and understanding that's part of it. But those that I've talked to that are either across the country or not local with me are having a hell of a time being able to get that prescribed. It's great.
Interesting. And maybe, I mean, telehealth is becoming more and more popular here.
Yeah.
So whether that's an option, you know, where it's harder to find balanced clinicians, you know, having a core group who can offer telehealth consults, or doctors or sports doctors or GPs who are happy to consult someone over telehealth could possibly be an option. But, you know, it is understanding those DVT risks. I mean, someone might like to brace if they don't have a high risk of DVT, so there's no risk factors for that person, they're quite young, so the risk is still going to be low. They may decide to brace and monitor. They need to be aware of the signs of DVT, what they can do to prevent it. It's just, I mean, rates of DVT, asymptomatic DVT after ACL surgery is as high as 31%. So it is really common after ACL surgery. But we don't want anyone having, you know, a symptomatic DVT. So that's just something, something to consider.
It's interesting. It's something about, you know, the medicine. I mean, you know, in general, it's not, you know, people will ask me directly, like, okay, well, what if I was in a cast? Would I be on a prophylactic DVT? And I'm like, all right, listen, the recommendation is that you're on it, you know, that you're on this. Like, there is reason behind their research. There was vascular surgeons. There was people consulted on this to make sure this doesn't happen. This isn't a light conversation. You know, it's not, it's a DVT can lead to death. Like you don't want that for something that you're just trying to heal your knee with. So, you know, making that the very strong recommendation and saying it's on that is obviously what I'm doing from that side. But it is, I would say that in the circle that I have gotten so far, or people that I have talked to, that it's the hardest part. Second to getting timely MRIs. Yes.
Interesting. Yeah, that's interesting that's quite a barrier in the US. I mean, because there could be another way. There could be an easier way to manage the DVT risk, but at the moment we're just erring on the side of caution, you know.
Absolutely. Absolutely.
There's over-the-counter medications as well that can help to reduce DVT risk.
Yeah.
You know, so maybe there are
even
other
just like
options.
in the beginning when it was, you know, from the protocol side, when it was like that, you were screening everybody for a DVT prior. I had a young guy going into this who had, you know, moderate swelling, but he was 90 to 30, but able to move. And he was just trying to get a Doppler to rule out that he wasn't developing anything. And that was a production to just get, you know, again, I think it's on the preventative side. What, you don't have a problem? No. What, you don't have a problem? The preventative side is pretty tough here. And some of that just might be finding the right people, you know, on side, but like I said, that's good. And then, you know, like my physician, like going across state lines and stuff like that, we have licensure issues and, you know, some fun barriers that we will encounter along the way. But it is interesting that is a barrier in in the, implementation of it for sure.
Okay.
So,
Yeah, that's really
well,
interesting.
FYI.
Yeah,
So,
yeah.
yeah.
Yeah, we'll
So,
see if we
but
encounter any challenges with a large clinical trial. Everyone
Yeah.
will be receiving.
Yeah. So, but yeah, I mean, I think it's really great that the research out there. I think people are looking for that, like Matt said, like on this platform, which we're only on YouTube. Our ACL topic where we're talking about bracing and non-op care is really one of our highest ones, despite some fabulous guests. So people are searching it, and
Yeah.
looking out for
Yeah.
fun, which is really cool.
Yeah.
So,
Great.
yeah. So thank you again.
Yeah. Appreciate you making the time.
Thanks a lot. Yeah, thanks for
Yeah.
the invite.
Any,
Come along.
any of the websites and the decision tree charts, email it to me. I'll put it in our comments of description of the episode so people can find those resources. So anything, any other resources that you think are valuable for the layman to kind of ground them in being the best educated consumer, share that, and we'll make sure that
I can link in some papers as well, especially those clinical trials.
Do it. Love it.
And yeah, I'll send you through a few resources and the online patient decision aid. The other thing is, anyone uses Twitter, or shall we say X now, is it? Twitter X?
Yeah.
Yeah, that's where I share all our new research, our resources for clinicians.
Perfect.
Working on some free training materials for clinicians and ACL managers
Amazing.
as well.
We'll cut up, 5 or 6 clips from this episode and share it across all the socials. So we'll make sure to tag you too. So you can take those and run with them, do whatever you want. So
no problem. Yeah. So at Steph Filbay is where you can follow me if you want to stay in touch with our research.
I'll find you. Yeah.
Okay.
Yeah.
No problem. All good.
Yeah.
Perfect. Okay.
Great. Thanks, guys.
Thank you so much. Elle,
you.
thanks for making this happen. Everyone can like and subscribe down below. We'll see you on the next episode. And one guy, 2 doctors. Love it. Appreciate it.
We're going to bed. Stephanie's getting started with your day.
Yeah, she's just hitting. She's just ramping up. Yep, we're gonna shut it down here in the States. So appreciate it again, and take care. Have a great night, everyone.